Hi, everybody. I'm with Alice, Leora, Jennifer, and Han today, and we're going to be talking about oral presentations. Specifically, the title of our screencast today is Highlighting Your Clinical Reasoning on Rounds. So, the goals of an oral presentation are multiple. So, one of the most important things is that it's a way of transferring information from one provider to the next, and that will hopefully be important in taking care of the patient. In addition to that, learning from the cases is an important goal of oral presentations on rounds. And finally, it is an opportunity for faculty and residents to evaluate the learners. So if you look at the um, medical literature, a highly significant relationship between students receiving honors in pediatrics and an A on the case presentation exists. And another paper shows that the majority of student interaction with attendings in emergency medicine occur during their oral presentation. So the other interactions really aren't directly observed. When we think about a great oral presentation, you can use a framework called the 5 C's as a way to think about the qualities of a good oral presentation. So they are complete, coherent, compelling, concise, and the speaker's composure. So let's break it down. So when we think about a complete presentation, I ask myself, are all the necessary details critical for decision making reported in the subjective and objective sections? Are the important illness scripts mentioned in the HPI? And are the most important problems, both ongoing and new problems, reported by the student? When we talk about coherent really refers to the organization of the presentation. So, does the presenter report the information in the expected format? For daily rounds follow-up presentations, we use the SOAP format presentation. And then for new admissions, you are familiar with the usual order in which a new admission note is written, right? With a chief complaint, the HPI, past medical history, medications, etc. The next question that I think about is it absolutely necessary to report the ED course in the HPI? Something to think about because oftentimes reporting the ED course with all the exam data and laboratory data may actually lead to some disorganization of the presentation. Compelling refers to the clinical reasoning behind the presentation. So there are several questions here. Are the data presented such that it builds towards the leading diagnosis in the assessment? Are the evidence presented that make the alternative diagnoses less likely? For new problems, is a differential diagnosis offered and the prioritization explained? And for ongoing problems, is the problem improved, the same, or worsening? Is the therapeutic or diagnostic plan clearly laid out? And finally, when we think about concise, are there extraneous details mentioned in the subjective, the exam, and laboratory data? Are less important problems mentioned in the assessment and plan? There's also the composure, which really refers to how the student or learner appears to the listener. So, does the student maintain eye contact? Is the student's voice projection too loud or too soft? Is the pace of the presentation rushed or too slow? Is the tone dynamic or monotonous? And is the presenter enthusiastic during their presentation? Is a presentation fluent or interrupted by ums, likes, editorialization? And does the presenter appear confident or anxious? So really think about the body language when you're doing your presentation. So in general, I my recommendation is that you structure the oral presentation in this fashion. Start with a one-liner. So the one-liner serves to get everyone on the same page. I usually recommend using the same format for a one-liner every single time. So the example is Mr. Smith is a such and such year old man with a past medical history of whatever disease are relevant, who presented with a chief complaint likely due to the presumptive likely diagnosis, as well as additional important issues and problems. So the phrases that are in red are what we call signposts, and they help us to think about the case before the presentation. Follow the SOAP format. Use transitions such as overnight, this morning, on exam, labs are significant for, problem number one, problem number two, differential includes, and that really helps uh, the listener figure out where you are in your presentation. The subjective, of course, refers to the overnight events followed by how the patient's feeling this morning. In the objective, start with vitals, the pertinent exam findings, and the laboratory and imaging results from the past 24 hours. Present the problems in descending order of importance and limit them to the issues where there is actually something to be discussed with the team, and then offer an assessment and diagnostic therapeutic plan for each problem. So we're going to watch a practice presentation that Alice did before she actually goes on the wards. And so we'll listen to see how she does her presentation.
Mr. O is an 80-year-old man who is here for evaluation of periumbilical pain, most likely related to impacted gallstones. So the patient reports that he slept well overnight. His pain has improved since we increased his dilaudid from 0.2 to 0.4. He's breathing comfortably with no complaints of shortness of breath. This morning he does endorse continued intermittent shooting periumbilical pain that he does not think there's a trigger for, but he does think it's reproducible by movement. His vitals are stable this morning. His temperature is 37 degrees, heart rate is 64, blood pressure is 100 over 61, respiratory rate is 18 breaths per minute, and his O2 sat is 95% on room air. On exam, he is in no acute distress. He's resting comfortably. His head exam was normal. His cardiac exam was regular rate and rhythm. S1 and 2 appreciated. His lungs were cleared to auscultation bilaterally. He's breathing comfortably this morning, and his abdominal exam was soft, non-distended, tender to palpation in the periumbilical area with no rebound or guarding. His ileostomy output is semi-formed tan stool. The consistency was similar to yesterday. His right lower extremity appears to be a little more edematous compared to his left, but gross movements are intact. There's no erythema, his sensation is intact. The same in both legs. He's alert and oriented this morning with no focal deficits that I can see. In terms of labs, his creatinine has continued to downtrend from 1.3 yesterday to 1.19 this morning. Otherwise, his lights are normal. He does have a mild, stable normocytic anemia with hemoglobin of 10, but there's no leukocytosis. His alk-phos continues to downtrend. It was mildly elevated, 148 yesterday, 117 this morning. Otherwise, his LFTs are normal. So Mr. O is an 80-year-old man with a past medical history of chronic pancreatitis, ulcerative colitis, status post proctocolectomy with end ileostomy, small bowel obstruction, status post bowel resection, COPD, and coronary artery disease, status post CABG, who presents here for periumbilical pain evaluation that was initially worked up at an outside hospital and showed concerning signs for impacted gallstones. He was transferred here for ERCP with advanced endoscopy for further evaluation. For his probable gallstones with chronic pancreatitis, we're going to continue to give him fluids at 100 cc's per hour, sort of taking a conservative approach towards giving fluids because his cardiac function is not really known to us. He's going to go NPO except for meds, starting at midnight tonight in advance of his ERCP. He has shoulder and lumbar spine pain, and for that we're just waiting for results of his SPEP and IFE to rule out multiple myeloma. Also in the setting of elevated creatinine that was present yesterday. We sent those tests out, we're waiting for those results. For his acute kidney injury, creatinine level of 1.3 yesterday and day before has downtrended to 1.17 this morning. His baseline has been unknown. So we're just going to continue to trend the creatinine. Also, his urine output has been low. And so in the context of sort of his creatinine that was elevated yesterday. We're just going to continue to monitor his urine output today. And that's it.
So now what we're going to do is we're going to go through an evaluation of Alice's practice presentation in order for her to get better at it. So why don't you guys take it away?
Yeah, so as far as completeness, Alice overall actually does a pretty good job of mentioning most of the relevant clinical data. Specifically in the subjective portion, there's a nice description of the overnight pain. It was good of her to mention the medication change overnight, and she hits a lot of the relevant questions from the OPQRST assessment. She also does a good job of mentioning the breathing, which is relevant given this patient's past medical history. On the objective, it's good that she includes all of the vitals, but there are a few minor things that she should have included for completeness. One would have been a description of the chronic shoulder pain, which she mentions only in the assessment and plan when discussing the multiple myeloma possible diagnosis. Also, since this is a patient with a kidney injury, it would be nice to know the BUN and the urine output as well. So another thing is that the one-liner is a little bit short, and this relates to coherence. So overall, Alice does a good job of following the SOAP format with clearly delineated sections. But from the very beginning, the one-liner lacks some of those silencing elements, which are the important anchoring past medical history, so that as we're going through it, we don't know necessarily physical exam findings and subjective findings we should be looking out for until we hear the more complete one-liner that she puts at the beginning of her assessed plan. As far as the plan, it's generally well organized, but the multiple myeloma does come as a bit of a surprise since nothing relating to it is mentioned previously.
Thank you.
In terms of conciseness, Alice actually did a really great job of keeping it to a very appropriate length and timing. She mentions only the pertinent and relevant exam findings and really does a great job of keeping it to a good length. There were some sections in both the subjective and objective portions that probably could have been cut out. Things like vital signs are stable, S1, S2 appreciated, and she talks a lot about the ileostomy output, which was slightly superfluous and not entirely relevant to her current presentation.
In terms of compelling, so she did overall a pretty great job with presenting the assessment and plan by problem. One thing she could have done better was instead of listing the problem of probable gallstones, she could have more generally just said her umbilical pain, especially since the etiology has not been worked up yet. And that relates to discussing the differential and clinical reasoning behind the most likely diagnosis and plan. So she didn't really give her own reasoning for why the periumbilical pain is due to impacted gallstones. She just kind of goes off of the outside hospital workup. And so that there was a discrepancy there because usually periumbilical pain is not clinically consistent with impacted gallstones, and she doesn't really explain why. One good example that she did have in her presentation that demonstrated good reasoning was she mentioned how they wanted to take a conservative approach towards giving fluids because the patient's cardiac function was not known. So that was a great example. And then for composure overall, she was very well composed. She maintained appropriate tone and eye contact. She was pretty self-assured while presenting data. However, at the end, she did trail off a bit when she was discussing the assessment and plan. And she sometimes uses words like "we're gonna," and she has a number of uhs and lip smacking sounds. But overall, was pretty well composed.
Great. So using this this feedback, Alice actually did a repeat presentation of the case, and I think that you can see some of the ways in which she incorporated the feedback.
Mr. O is an 80-year-old man with a past medical history of chronic pancreatitis, ulcerative colitis, status post-proctocolectomy with endoileostomy, COPD, and coronary artery disease, who presented 2 days ago for evaluation of periumbilical pain due to impacted gallstones complicated by AKI. There were no overnight events. The patient reports that he slept well. His pain has improved since we increased his dilaudid from 0.2 to 0.4 IV. He's breathing comfortably with no complaints of shortness of breath. This morning, he does endorse continued intermittent shooting periumbilical pain that he does not think there's a trigger for, but he does think it's reproducible by movement. His shoulder and back pain are still 2 out of 10 and unchanged from yesterday. This morning, his temperature is 37 degrees, heart rate is 64, blood pressure is 100/61, respiratory rate is 18 breaths per minute, and his O2 sat is 95% on Romer. On exam, his head exam was normal, cardiac exam was regular rate and rhythm without murmurs. His lungs were clear to auscultation bilaterally. His abdomen was soft, non-distended, tender to palpation in the periumbilical area with no rebound or guarding. His ileostomy output is unchanged. His right lower extremity appears to be a little more edematous compared to his left, but there was no erythema. He is alert and oriented this morning. In terms of labs, his creatinine has continued to downtrend from 1.3 yesterday to 1.17 this morning. His BUN decreased from 38 to 20 after receiving IV fluids. Otherwise, his electrolytes are normal. He does have a mild, stable normocytic anemia with hemoglobin of 10, but there's no leukocytosis. His ALK phos continues to downtrend. It was mildly elevated 148 yesterday, 117 this morning. Otherwise, his LFTs are normal. In terms of assessment and plan, his first problem, his abdominal pain is likely secondary to chronic pancreatitis, given its periumbilical location, but we have to still consider impacted gallstones given the workup at an outside hospital. We will continue to give him lactated ringers at 100 cc's per hour, taking a conservative approach towards giving fluids because his cardiac function is not known to us. We will continue dilaudid at 0.4 milligrams IV as needed, and he will be NPO at midnight in advance of an ERCP tomorrow. For his second problem, his acute kidney injury is likely pre-renal in etiology given the BUN creatinine ratio and calculated FeNA of less than 1%, as well as his NPO status, which may contribute to dehydration. This has continued to improve as his creatinine has downtrended. However, his urine output has remained low, so we will continue to trend his creatinine. And his third problem, his shoulder and lumbar spine pain are chronic, and in the setting of mildly elevated creatinine and chronic anemia, make us concerned for multiple myeloma. We are currently awaiting the results of an SPEP and IFE. His pain has been adequately controlled with his current dilaudid regimen.
So great job, Alice. So I think that her presentation really now highlights her clinical reasoning much better than in the previous example. Let's try a different presentation from Han, and we'll apply the same 5Cs framework to see how he does here.
Mr. Y is our 84-year-old patient who came in with congestive heart failure with iron deficiency anemia in the setting of an occult GI bleed and chronic kidney disease. This morning, he's feeling well. He's reporting no shortness of breath or chest pains, and he's eating well. He's not yet walked, saying it's difficult, but he hopes to do so today. His vitals over the past 24 hours have been in normal range. He's been afebrile. Heart rate is between 60 and 80 beats per minute. Systolic blood pressure between 112 and 128. His weight is down to 47.4 kilograms from 54 kilograms on admission. Over the past 24 hours, he's put out 3.8 liters of urine. On exam, he's looking cachectic but comfortable in bed today. His heart is now in sinus rhythm for the past 36 hours. His lungs are clear in the upper lung fields, but breath sounds are absent in the lower lung fields. His extremities, now his lower extremities are no longer edematous. However, he does have a new focus of inflammation near one of the tophi. In this case, in his first metatarsal phalangeal joint, likely gout. Labs today are notable for a bicarb of 38 and a creatinine of 2.16 down from 2.3 yesterday. Additionally, his hemoglobin is stable. It's at 8.5 today from 8.3 yesterday. And we got a PSA of 0.54 today, and we're trying to track down from his primary care provider what his normal PSA is. Imaging this morning was a chest x-ray, which showed his large pleural effusion remains largely unchanged. So in summary, this is an 84-year-old man who came with congestive heart failure, 4+ mitral regurgitation, hypertension, chronic kidney disease, gout, and a history of treated prostate cancer with increasing shortness of breath. He's doing much better now from that standpoint and is no longer edematous. However, his pleural effusions remain, and we're concerned the anemia and cachexia may represent an occult malignancy. Therefore, we want to get him to colonoscopy before we consider a mitral valve repair. And to do this, we're hoping to get some of the fluid out of his pleura. So today, we're going to do a thoracentesis, drain some of that fluid, and then try to get him scheduled for colonoscopy. Additionally, we'll diurese him with Lasix again, just 80 milligrams once today. We're going to cut his sodium bicarbonate, given his serum bicarbonate levels, and we're starting 3 times a day prednisone for the gout, or the likely gout flare-up. Other than that, we're maintaining the current treatment.
All right, why don't we apply the same 5Cs framework to give Han some feedback?
So once again, Han does a good job of including a lot of the relevant clinical data and making a fairly complete presentation. His one-liner includes some more of those important signposts, but it's still missing prostate cancer, which comes into play when he's discussing the objective portion of the presentation. As far as his subjective presentation, he does a good job of mentioning the pertinent negatives of no shortness of breath or chest pain in the context of the CHF. But very importantly, he starts off by saying this morning and doesn't mention any overnight. So even if nothing's happened, it's still important to at least say there were no events overnight. It also would have been good for him to include some mention of bowel movements given this patient's presenting complaint. In the objective portion, it was great that he included the trend in weight as well as the urine output, but an important finding to include would have also been whether or not this patient is on oxygen. In the physical exam, a few of the key findings that it would have been nice to hear about would have been the presence or absence of crackles or JVD, and given the history of MR, it would have been good to hear a discussion of whether a murmur was appreciated or not. Also, since he does have a GI bleed, I would have liked to hear a little bit more about the abdominal exam. He mentions near one of the tophi in part of the physical exam, but this is the first that we're hearing about the tophi, and we don't know if it's chronic. We don't even know if it's on the left foot or the right foot, though within that foot, he does a good job of explaining the exact location. Also, since we know that this patient has anemia, we would have liked to hear something about conjunctival color. And then within the assessment and plan, when discussing the extremities, Han says no longer looking edematous, but it would have been helpful to quantify using a comparison to a previous exam. And also, sorry, in the assessment and plan again, since they're dealing with CKD, it would have been nice to hear a little bit more about that. As far as the coherence of the presentation, it's a little bit out of order. They mention a diagnosis during the objective portion when they're talking about the tophi, and he sort of offhand says likely gout. And there's also some editorializing when discussing the PSA and saying that we'll try to get it later as an explanation for why they don't have it right now. With the assessment and plan, that felt a little bit disorganized because it was organized chronologically in terms of the steps they wanted to take as opposed to organized by problem, which tends to be easier for the listener to follow. Also, this is a minor point, but sometimes he states the treatment before the diagnosis, as in saying that he'll use prednisone to treat the gout, instead of saying I have gout that will be treated with prednisone.
Okay, so in terms of the conciseness of Han's presentation, he did a good job appropriately only mentioning the pertinent vitals and lab values with their trends, including the weights and the outputs. And in the labs, he only talked about the relevant bicarb and creatinine with the trends and stable hemoglobin values. When he mentions that they were trying to track down the baseline PSA, he puts that in the objective, which is a little bit superfluous, as it's a little bit of editorializing and can be talked about later on. And additionally, in the beginning of talking about vitals, he says his vitals have been in normal range and goes on to mention their exact values, which is a little bit unnecessary, though minor. And as Leora mentioned when discussing the completeness of Han's presentation, overall the presentation was lacking its completeness and contributes to also being maybe a little bit too concise.
In terms of compelling, so we had previously mentioned how it is important to build up to your leading diagnosis, and that starts with the one-liner. In his case, his one-liner was a little confusing. He said that the patient came in for CHF, but then also refers to iron deficiency anemia in the setting of a GI bleed and CKD. So it was unclear whether those were part of the reason for his admission or part of his past medical history or both. It could have been better instead to say 84-year-old male with a history of CHF, CKD, gout, and treated prostate cancer, presenting with shortness of breath and a new iron deficiency anemia, so that also, as Leora had mentioned, by the time that he gets to the physical exam or the labs or the assessment and plan, we are not surprised by any of the new information such as the TOFI or ordering the PSA. And so that would give context for when he gets to that part of the presentation. Overall, he demonstrated understanding of what was being done for the patient and the reasoning for the sequence of what was being done. He was able to identify that the CHF exacerbation was improving. He knew that the thoracentesis had to be done before the colonoscopy, which had to happen before the mitral valve repair. And he knew that that way he had to continue Lasix for the pleural effusions. But if he had organized the assessment and plan better, and meaning organized it by problem, it would have allowed him to explain the differential and the reasoning behind diagnosis and treatment much better. In terms of his composure, he was well paced. He maintained appropriate eye contact and volume. He was very self-assured and confident in his overall presentation and plan, and he used very few filler words. So he had pretty great composure.
Well, thanks everyone for the feedback, and let's see how Han has improved his presentation.
Mr. White is our 84-year-old male with a history of congestive heart failure, chronic kidney disease, gout, and treated prostate cancer, who presented here 2 days ago with increasing shortness of breath secondary to a heart failure exacerbation, and was found to have a new anemia in the setting of a possible occult GI bleed. There were no acute events overnight. This morning, he's feeling well. He reports no shortness of breath or chest pains, and he's been eating well. He has not yet walked, saying it's difficult, but he hopes to do so today. Over the past 24 hours, he's been afebrile. Heart rate is between 60 and 80 beats per minute. Blood pressure has been between 112 and 128 systolic, 55 to 60 diastolic. He remains on 2 liters oxygen by nasal cannula. His weight is down to 47.4 kilograms from 54 kilograms on admission. Over the past 24 hours, he's put out a net 3.8 liters of urine. On exam, he appears cachectic, but is resting comfortably. He has no conjunctival pallor. His cardiac exam was regular rate and rhythm. No murmurs, rubs, or gallops were appreciated. His JVD was normal at 8 centimeters. His lungs were clear in the upper lung fields, but breath sounds were absent in the left lower lung field. Did not appreciate any crackles. His abdominal exam was soft, non-tender, non-distended. Bowel sounds were present in all 4 quadrants. His lower extremities are no longer edematous bilaterally, down from 1+ yesterday. However, he does have chronic tophi on his left foot, and there's an area of redness and tenderness near a tophus in his left metatarsal phalangeal joint. Labs today were notable for a bicarb of 38 and a creatinine of 2.16, down from 2.3 yesterday. BUN today is 35, down from 45 previously. His hemoglobin is stable at 8.5 today. It was 8.3 yesterday. His PSA was 0.54, but his baseline is unknown to us. Imaging this morning was a chest x-ray, which showed a left pleural effusion that remains largely unchanged. On telemetry, his heart has been in sinus rhythm for the past 36 hours. So assessment and plan by problem. His CHF exacerbation is improving as he's breathing more comfortably. His weight is down, and he's no longer edematous. However, his left pleural effusion remains, and so today we're going to do a thoracentesis to try to drain some of that fluid. Additionally, we'll diurese him again once a day with Lasix, 80 milligrams IV. His CHF is complicated by known mitral regurgitation, but will hold off on pursuing surgical options until after rework of his anemia. Regarding his anemia, his hemoglobin has been stable, and we suspect that in the setting of his cachexia that this may represent an occult GI malignancy. After the thoracentesis and with more diuresis, he will likely be able to tolerate colonoscopy, and so we will consult GI today in preparation for that procedure. Given his history of gout, the new inflammation on his left foot likely indicates a flare-up, and so we'll start prednisone 40 milligrams daily. Lastly, his stage 4 CKD is being managed with sodium bicarbonate and darbepoetin supplementation.
So great job, Han. So one of the things I want you to remember is that Sherlock Holmes actually is written by a physician, Sir Arthur Conan Doyle, and it really highlights the fact that what we need to be doing as a student and as a resident is to be a detective and a good storyteller at the same time. And that's where doing a good job with your oral presentations really come in. So in summary, consider carefully what you're going to say on rounds, because this is all about your clinical reasoning. Practice does make perfect, and if you want to get better, I think the self-assessing using the 5Cs framework can be really important and helpful. Remember that there are two stories, the patient story and the physician story, and a good presentation will really incorporate elements of both. So really be great at storytelling. Thank you very much for your attention.